Welcome, everyone. I appreciate everyone taking some time today to come to our subcommittee. Our agenda is posted on the website and could probably put it in the chat, right, Tara?
Yeah, I can do that real quick.
Thank you.
Hi, it's Kathy Marcioni. I'm actually not finding the agenda on the website. Did anyone else?
Oh, here, if you go to, I'm going to share my screen.
Yeah, I was going to say it is down below. You have to really scroll down to
Share.
find it.
Let me
I
hold on.
scrolled down to. No, I didn't. I got
All
it.
right.
I got
So
it.
is everyone seeing? Okay, yeah. And then you just go
Found
to
it. Thank you.
meetings,
Mhm.
and then this is the ledge meeting, and then agenda.
But thank you for asking that question because I'm sure other people may have had a challenge finding it.
And sometimes, like, I'm the one who does all of the website stuff, and sometimes I'll publish the content and everything, and then the links are not right or something. So if you ever have any issues, let me know because it could be I was not an IT person, so it could be me.
Okay, so we have the minutes from our last meeting that we need to approve. Tara, were they sent or can we put them in the chat for?
Yep, I can put them in the chat. I'm on the website.
I'll give a minute for that. Is there anyone that would care to approve the minutes? Do I have any takers on minute approval?
Just has to be someone, a member of ASDAC.
Hi, it's Carol. I'll approve.
Thank you,
Thank you,
Carol.
Carol. Do I have a second?
I was not present, but I just glanced through them and I will second it for you.
Thank you.
Thank you. Appreciate that, Carrie. Okay. So we have the bulk of our content today is going to be really about our legislative priorities. There is a short session that was just announced that will be starting November 12th and November 13th. I think it's just a few days. It doesn't sound like it's going to be very long. And Tara has already agreed to keep an eye out for anything that would be of interest to us. But given some of the bigger issues, I'm not anticipating too much that will be happening in our concern. The main session will be starting in February, and in preparation for that, I really wanted to hone in on our top three priorities and discuss any approaches that we may want to take around those. So already on our agenda, if you will, for our priorities has been to continue working towards the change in insurance law to allow for BCBA services for life. That's where we would like to go. Although last year, as you know, a bill was proposed to change it to 26. It passed the House. Due to what I understand was some clerical mishaps, it never made it to the Senate. So it will have to start over. But I'm I'm really hopeful because it did seem like it had bipartisan support. So, is there anyone that would like to comment on us pursuing that, continuing to pursue that as a priority?
And just a reminder, we also sent out letters sup- to legislators asking that it be reintroduced in special session. So there is a possibility.
Are we good for that? The second one was something that was brought to our committee, which is around really the waiver reform. And waiver utilization is not just due to lack of staffing, that some waiver participants are using the minimum and they don't feel like they need more. And we've had multiple conversations about this in the past. So to talk about being able to support the idea that people use what is needed. Carol, since you're the one that's been most active in pursuing this topic, do you have anything that you'd like to add to that at this point?
No, I mean, I think I shared most of that information. I know Tara was going to look into utilization at some point as well.
Yeah, I think that well, right now DSS is a little swamped with all of the other um federal shutdown and, cuts and SNAP and all of that that's going on. But I do think that if we want to discuss this further, it would be good to maybe come up with some questions and what we want to clarify with DSS and maybe invite Susan to attend our next meeting so that we can get some additional clarity on that and then see what the department itself is thinking as far as if they're looking at any kind of because I know they've been working on waitlist reform in general and doing some proactive measures for that. So it would be good to kind of get their standing on where they're at as far as um, low utilization and, um, all of that kind of stuff. So if we want to come up with a list of questions that it would be good to maybe we can send that out to them in advance and ask Susan to attend either our next meeting or the one after.
Yeah, I think
That's
they
my
know the answer
suggestion.
to the first question that I would ask, but I think so what is the minimum usage required?
Mm-hmm.
And I think it's one service per month, 1 hour of one service per month. Maybe it's not even an hour, maybe it's just one, it could be 15 minutes, I don't know, but one service
Mm-hmm.
which I think that would be, I would think that that should be looked at. And if somebody's only
Mm-hmm.
using one service per month, I would like to know what the average utilization is and maybe, what percentage of individuals are using under 25% of their budget or under
Mm-hmm.
50% of their budget. Um,
Well, it wouldn't be, I think we would want to word it.
Kara, you word it however you think you should word it.
Yeah, I'm thinking because I'm thinking so it wouldn't necessarily be of their budget. It would be the utilization based on the 50,000, right? Is that what you would be more interested in? Like,
Yeah, yeah, absolutely.
okay,
So if their
okay.
budget is right, so I mean, I think everybody's budget is 50,000, but that's how much
Well,
is allocated to them, but that might not be what's in that's not what their IP is.
what's in there, right? So if their IP has,
2 hours a month and they
2 hours
use,
a month, then that's what their quote technically budgeted for, which they could be using 100% of what they're budgeted for, but that would be different than how many people are underutilizing the $50,000.
right. So what is the average utilization of funds per, and that probably would be easier for them to run because they would just be able to
Right.
run names and
Mm-hmm.
say, I don't want to be a jerk, but I do know that what DSS, well, so maybe I do want to be a jerk, but I do know what DSS is going to say is that it's about staffing and not finding staffing. And that's what they're going to hang their hats on in the first thing. But that's actually not my experience, at least in my part of what I'm doing.
Well,
So,
we could ask a follow-up question to that to say, like, we know that that's true, that there are people who are struggling to find staff, but how do they know that that's the primary issue?
Right.
So, okay, got it.
Kathy has her hand up.
Yeah, if I'm remembering it, this conversation has been going on a really long time. And if I remember, the original question was, if everybody's has the ability to use up to $50,000, but we know that there are some number of people who have waiver slots, who have had them for many, many years and only need a small amount. Like, that's not about anything else. We know that they need a small amount. And the program I work in is not a waiver program, so I'm not knowledgeable about the guardrails around Medicaid waiver. But I guess the question is, we know ultimately it's a budgetary issue. The reason there's only so many slots is because of budget limitations, right? So I think what our ask always has been is, can we stretch those dollars further to cover more people without having more dollars allocated? So if someone is allocated 50 and they're only using 12,000 a year, and we know 2 other people who are coming up on the list who could really benefit from that, can we have people sort of share a slot? And if that is a hard no, like if we can read in the Medicaid regulations where that is an absolute no, then we don't need to discuss it anymore. But if there's any wiggle room in those regulations, then I say that's where we try to drive through.
There is wiggle room in the sense that we write the waiver. So if we would like to, the conversation, like you said, Kathy, has been around tiering, right? So maybe because we have low utilization, should we look to maybe create like a $25,000 cap and then a $50,000 cap? And then if we did that and move people into that lower tier, so to speak, then could we potentially open up additional waiver slots? So that, like, as a way to help with managing the wait list. But I also think personally that we need to talk about the wait lists in general, because if we are having people come in, I think that there's a difference between assessing the functional needs of somebody who needs some services, but they may just need a little bit of service, to somebody who's getting on the waiver because their name got pulled and they've been waiting for this for 14 years. And now they're at the top of the list and they may not need anything now, but they want to have access in case, so is there a better way to look at onboarding people into the waiver who have a higher level of need, I think is the other question that has come up from in this conversation too. Because right now it's just purely first come, first serve.
Right. I mean, I feel like there's people who've been on the waiting list for a long time, and they're sort of not, it's good that they've been on kind of on their own, but those people are maybe 35 or 40 and they're, have their jobs and their apartments and things like that. And then we have kids that are graduating from high school that have a gap of no services, and that's where they sort of plummet. And then we get a lot of other crisis stuff and mental health stuff because they go from all the support to nothing.
Right.
I think I would love to see the prioritization of not of kids, because kids have school district stuff. Not that I don't like kids, but the kids have schools. That's who's responsible. But for those kids, the people that are 22 and graduate
older.
or get a diploma at 18 and graduate, can we use some of that funding just to stabilize people in that age group, that 18 to 25?
And
Yes.
yeah, and could that be like the proposal? Like, we're going to open up like waiver slots by tiering. Could we manage that in a different way? I mean, that's similar to what DDS does. So they do a budget ask every year for planning for the age out grads. And they don't necessarily, for that waiver, for that particular waiver, it's really looking at employment and day supports, which we have in our waiver. We also have, BRS does some of that transitional work as well. But we don't really have any day supports written into the waiver, like nothing like that exists for those kids. We have mentoring and some other services, but we don't really have. So I think if we were going to do something like that, we would also need to look at what services we're offering. And this is one of the things that we wanted to try to capture in the needs assessment too, so that we could do some more strategic planning as we're identifying specific needs. So that can all be part of this. I mean, I think the work should begin now, even though we don't have the assessment. But in conjunction with the assessment, those were some of the things that we were hoping to have some hard data on. Carrie?
Yeah, I was just gonna, and you just sort of spoke to this, but I was just going to, kind of shine a light again on the fact that if we are, and I think it's a good problem to have, right, bringing people off of the waiver and having more people, giving more people access to services, but if in which case we don't have, it'll be an additional drain on the existing services, right, that are out there. And we know that there is a dearth of opportunities and providers. So it just kind of brings us full circle, chasing our tails once again of how do we increase the number of available services to our folks who fall into this sort of gray space and could really benefit from day services, life coaching, whatever the case may be. But it's great to give people opportunity to financial resources, but if they can't be plugged in anywhere, because those things are maximized, what do we do about that?
Right, which leads us back to the workforce conversations, right?
Exactly. Yeah, right. This is why I'm chasing my tail.
Yeah, I know. It's
really
a
acknowledge that.
big, ugly loop that we're living in.
And I have another kind of to tag onto that a little bit. And I'm going to maybe put Jennifer Crom a little bit on the spot. Sorry, Jen. So we just, and I don't know how I missed this, but there's been new regulations about the requirements, the educational and training requirements for behavior technicians through Medicaid, and it's made them higher. We used to have those same regulations on the waiver program, and they reduced them because we couldn't find staff. And now I believe there's a current staff who are already working before July 1st of 2025. They are grandfathered in, but new staff have to meet these educational requirements. Is that something that's going to happen with the waiver program too? Because that'll just make it even more difficult. I know, Jen, it's requiring a bachelor's degree or a mass or an associate's with an RBT, and there's it's pretty heavy requirements.
So we actually changed it to include the high school diploma with an RBT, which meets the BACB guidance. The change to the bachelor's degree and associate's degree was if they didn't have a degree or experience in the area of working with kids with autism, then we're also requiring the RBT. But somebody can be hired with a plan to get the RBT, so they have the 180 days to get that RBT once they've been hired. But I think we were looking at both the quality of the behavior technician staff and wanting to make sure that they had that experience and education or the RBT. So that was the biggest change to that requirement.
Right. No, and I totally understand that, and I appreciate it. And being in the field, I know we need a but the issue that I have with that, I'm kind of going on off track a little bit, and then I'll be quiet. But I would not want the waiver program to pick up those same requirements, because having an RBT requires a BCBA that's supervising 5% of your hours.
Yeah.
And there aren't BCBAs out there, and it's a hardship even with insurance based. But so that RBT sounds great, but that's a lot of
there's
hours to
BACB requirements for it. Yeah.
So
well, and that's the difference between the waiver services versus insurance coverage type services. So right now we don't have anything written like that into the waiver because it's just, it's not like a medical approval for
Right.
waiver services. So I would not anticipate that would be added to, the waivers at all. So that's separate. That would be for all of those services for kids 21 and under.
I just wanted to put it out
Yeah,
there just
yeah.
because of the requirement of
Mhm.
supervision for the RBTs that, like, it sounds great superficially, but you gotta like, it's a hardship, so.
Yeah.
And so, and going back a little bit, what you were talking about, Tara, about the, when we we're talking about like focusing on the graduates maybe, or doing something like that, I feel like if we just advocated for this tiered system and open new slots, we would just be taking more of the same people who are more stable,
Mhm.
theoretically, and not focusing on the actual needs. So if we were going to make this change or ask about this change, it would seem to me to be, this would be a good time to talk about carving out some time for the new graduates.
Mhm.
I would even just, I do sit with DDS when they do their planning for age outs, and we actually start talking about kids at age 14 to start giving them projections of what their budgets could potentially look like. So even maybe, I know 18 is usually when kids could potentially be graduating at the youngest, but we could have 17-year-olds, or even just get to have those kids say, okay, we got our letter, we're going to be up, so it's not parents in absolute crisis mode a month until graduation, and then they find out that, oh, we could potentially be on the waiver. I think it might just help with some planning.
Mhm. Do we want to find out too, then we could say like, we could get some of the, we could get some additional wait list data too. We could request, what, um, age range is, currently on the wait list so that, maybe there's some ways we can carve out, um, kind of that we're making some assumptions, but maybe that data exists that DSS would be able to provide as well.
Yeah, I think it would be helpful, Tara, to kind of have some demographic information about who is on the wait list. Because then it might help us to know where's the greatest demand right
Mm-hmm.
now.
I mean, if you're looking at DSS data, then they also have like utilization in terms of emergency rooms, inpatient. We could also kind of gauge the intensity of the need of services before having that needs assessment. But also understanding that as well, you could have a 18-year-old who's never ever access to inpatient or higher levels of care. So that might still be included in that tiering system where somebody who might have that history of um, needing higher levels of care throughout their childhood be
Mhm.
bumped up in that
I'm
tiering
sorry,
system.
this is Toby. I'm with DRCT and I'm in this conversation late. But I'm trying to understand the landscape. Like, to what extent is Connecticut, to what extent do we know what the needs are? I guess I'm trying to get a better handle on it. Like, do we know the population, the demographics? Do we anticipate, already know these figures of like who's aging out of the schools? What is their utilization? Like, to what extent do we know these demographics and utilization rates?
So we would know them for who's we would be able to request the data for, on people on currently receiving waiver services. And what this discussion we're focusing on is the people who are currently on the wait list. So there's about, each month at our meetings, we get an update on number of people on the wait list, but we only really get a number. We're not getting additional demographic data. So that was part of our request. And then also, we don't know, like in Connecticut for the population at large, we only really know for those who are currently receiving services or waiting for services, which is why we're doing the statewide autism needs assessment, which the grant approval for that was received. So DSS and myself are working on securing a vendor to do that statewide needs assessment. So it's going to take a little bit, but we are looking to do that.
So you're, just to reiterate, we have data on people who are already eligible. And then we have some data on people.
Only if they're on the wait list. If they're eligible and on the wait list, we would have that.
And then we have data on people who receive services for the autism waiver, right?
Yes, correct.
And then do we have any data on youth and young adults who are coming up in the system and may need it in the future?
Only if they're also have a co-occurring ID diagnosis, which they
And
wouldn't
when does that
qualify.
start? When does that start?
So DDS is keeping track of that. So they do age out planning for kids with an ID diagnosis. But if you have an ID diagnosis, you're not going to qualify for the autism waiver.
Right, but when do those demographics show up in the system? Like, are they predictable? Like if a child is diagnosed early on with autism or an IDD, when does the state find out about that? Is that early on or when they're transitioning from education?
I think that DDS is planning for kids like starting at 14
But the data exists earlier and before that in
in
education
school
records.
and
We just
education
don't have it.
records.
Yeah, so
Right.
all right, so
Okay,
we
It
like,
also depends when people apply.
right.
The other thing we need to be considering. Can I just add my comment, which I think is relevant to what you're asking, Toby, is that forgive my ignorance, I don't know how old the waiver is. When did it start?
I've been with it since 2009.
Yeah,
and
I
that
was
was
gonna say
about, it was about
early
2008.
2000s. Yeah.
Okay. The reason I ask is we also might want to look at the data of the wait list and, who's been accepted over time, because I'm going to guess that there's increasingly younger kids and individuals being added to the wait list now than there were at the very beginning, right? At the very beginning, I mean, again, I don't have this data and I don't know anything about it, but my assumption is, adults were needing it at the time and joined. But I recommend to fairly young patients at this time now to get on the wait list. So I mean, I'm just representing myself, but I would suspect that the demographics have changed over time. So
Yeah, and that's why
number.
no, that's why
maybe-
I brought it up, because like
Yeah.
we're in a reactive mode right now. These are people who are already waiting or are on the waiver, and we're trying to understand their utilization. But what I hope in my position at DRCT is that we can get to a point where we're predicting what the need is, and we understand what the need is, like at a much younger age, from a prevention point of view or from a planning point of view for budgetary needs. So thanks
And
for
that's why we are doing the statewide needs assessment. So that was specifically approved through Money Follows the Person for long-term supports.
And
So that we can be planning for those long-term supports.
yeah, I just wanted to highlight that though, because I think, I still work with patients who've been told for the intellectual disability pathway, have been told by the school where their child attends for a while. And then we're talking at 17, I'm talking to them and they still haven't applied for DDS, right? So that's one pathway, and those people are going to get it. They don't have to fight for it or wait on a wait list, right? And then there's this whole group that definitely is either not aware, hasn't signed up, or they sign up when the kid is 17, 18, and we know they have at least 10 years wait.
Yeah.
And that's
Yeah.
why if you sign up on, if you have an autism diagnosis, so even if they're young and they add their name to the wait list, that's one of the things that DSS has been trying to work on in collaboration with DDS, is identifying those dual diagnosis folks who would be eligible for DDS services. So there is some I just want to assure everybody that there is some state oversight that they're going through that. So say somebody updates, their information, like they're actively keeping track of that and reaching out so that they can transfer those people over to DDS. once because say you put your kid, because they just have an autism diagnosis at first, right? And they go on the wait list. And then somewhere along the line, while they're waiting, they receive an ID diagnosis. So we are doing some oversight with that between the two agencies. So I just want to assure everybody that those kids are not getting, if they're on the wait list, those kids are not getting skipped over or missed.
So we
Carrie,
The ones that we know of.
Right, but they've already been on the list, you know, sat
Right.
on the wait list, and then they just get, you know, transitioned over and then right into, you know, access to services. But it's all of these people who don't know about it or are signing
Right.
up. and they,
right.
You know,
So
they
can
need it.
we get redacted data, like a data batch of people who across systems, education, Medicaid eligibility, like can we request that data to anticipate this? And not I mean we could like redact it. But like do we have that ability to get that information to make good decisions and like policy advocacy, like around like how we could potentially
Well, I think,
that-
Toby, that's the point again of the needs assessment so that we can reach out and get a broader audience beyond even who's on the wait list so that we can anticipate bigger needs and help drive some of our thinking around what do we need to ask, what are our asks for policy related to that? Because it's the system, the data is probably there in multiple places, but it's not always so clean just
Of
because the
course.
student, right? And the connectors are not always so clean. So I think we're our drive to look at that through a needs assessment is what's going to help us make those best decisions.
Right, so are administrative records part of the needs assessment, or is it surveys and focus groups? Because I think administrative records may be, although hard to sort through, which I've done a lot of with ICD 9 codes or 10, 11 codes, like it's not a clean process, but like, will we have access to redacted records to be able to try to get a total enumeration or a census, a big picture of what's the population versus hearing from people through survey or interviews, or no?
Well, we're right now just still securing a vendor. So we don't have that. But the initial thought was to not only look, identify those who are currently utilizing or eligible for Medicaid, but also trying to do a wider reach to those who may not be currently
Right.
eligible, so that we are kind of capturing as many people. And it is at this time a survey and focus groups is what is in the scope of work.
Yeah, it'd be great. I just want to put my 2 cents in. It would be great to like get redacted files on children under 22 who are already known to Medicaid. And then also through the all payer claim system, children who are known to other insurers in the state who may have diagnoses of autism or some other indicator that would indicate that they may be on the spectrum. So we have a sense of a total universe, and then we can get qualitative information from surveys and focus groups.
Mhm.
My suggestion.
And there is that data that's been captured, by the State Department of Education, which you can look up at any point. So I just want to make sure that we know that that data does exist. And it's just a matter of knowing which of those students would be moving on to adult services. Carrie, I noticed that you have had your hand up a couple times. Oh, you're on mute.
Thank you. Yeah, no, I was just going to suggest earlier that we could have, certainly the State Department of Education has numbers for kids who are classified or yeah, under the IDEA criteria for autism. So to the extent that that can allow us to anticipate, and there are so many variables in that equation that it's not going to be easy to discern which of those students, but also to Jennifer's earlier point about transition discussions starting to happen at 14. I mean, we all know that legally that's supposed to happen within schools at 14. So maybe some schools are doing a good job of advising families and, that the waiver even exists. I will confess that my son should be on that waiver and he is not, and that is my fault. But, there are lots of folks who really don't even know that the waiver exists, and schools could be doing a much better job. And I thank you, Sarah, for sharing with your families and letting them know early on, because there are lots of clinicians too who are not.
Yep. And Carrie, I'm in the same boat, right? So as a mom,
Yep. The shoemakers and
right.
your children.
And we know about the waiver, and to your point, how many families who don't know at least about the waiver. So it is helpful to think about that marketing and what we could do to help get that communication out there. Just for the sake of time, I do want to shift, and I want to thank Tara. We're going to take these questions to DSS and see if we can get additional information regarding the services, and then we'll be able to come back to the committee and talk about it. Tara, I do think it would be a great idea if DSS could join us in an upcoming meeting. If anyone wants to object to that, you can let me know, but it feels like it might be helpful.
Yeah, I can see if Sue, because I think that we would be able to have a more targeted conversation in this subcommittee based on some of the things that we want to look at from a policy perspective. And so I will ask Susan if she can attend our next meeting and if they could have some more specific numbers to share instead of just the general, how many people are on the wait list, how many waiver slots. And, I know that they're working to fulfill those case manager roles, et cetera. So, but this is more of a targeted conversation on overall how the waiver is executed in the state. So I think our next submission, don't quote me on this, and I know this is recorded, but I think it's 2027 or
Okay.
28. I'd have to look it up to see or ask Christine when our next waiver. I mean, you can always make an amendment, but our next waiver application would be due, I think, in a couple of years.
So it would be nicely timed with our needs assessment, hopefully.
Hopefully, yes.
Just to shift gears a little bit, so we have the two priorities for the legislative session. Is there a third? We haven't received, just so you know, any additional policy proposal requests. So I'm just opening the floor for this group here to think about what would be our third priority this coming season.
Toby?
I just wanted to, sorry, I had to join the meeting late. What are the first two priorities before we get into the third?
Oh, yes. So you just kind of heard the wrap up of our second priority, which is looking at reform around how the waiver is distributed. One of the things that's been observed is that some individuals, even though they have access up to 50,000, they may only use half of that or less. And we're really questioning if those resources can really go back into the system to maybe potentially open more spots. It's kind of just in an exploratory phase right now, but we really want to look more into that and talk more around a leveling system or a tiering system so that individuals are better aligned with what they really need. And the first priority is in Connecticut, because I saw that you said you were new to Connecticut. Connecticut, the insurance, the way services were written up in this insurance, it didn't cap it, but it said it was a minimum. It was actually a minimum provision till age 21 for BCBA services. And that is really the only service that happens to. So my daughter can have OT for life, but her BCBA services were capped by the insurance. So we're hoping to push on that agenda and raise the attention that we really need access to BCBA services for life. There was a proposal, a bill on the House floor that did pass, but never made it to the Senate to raise it at least until age 26. We're hoping to get that at least raised again, and ideally for life instead of just 26.
Thank-
So
That helps.
no problem, Toby. So what other agenda items or proposals for priorities does this group have? If there aren't any, that's okay. We can go forward with two. Um, more integrated, more competitive employment. Yeah, that Toby, that certainly is an area. Actually, I would expand that to say that even employment opportunities as a whole, to be able to do a better job with employers. I have some professional experience with especially our large corporations no longer really welcoming individuals with differing needs. They've been actually making it more restrictive, if you will, and harder to really get into the door. And so we've had to really search wide and far for job placements, much further than we have in the past. So I think there is a need to talk about how to better educate our employers or better connect with them to be able to hear more about, what it is as a gift actually to hire someone on the spectrum.
Yeah, I'd love to know more about that in a separate conversation, because I'm new. I've only been here since
Yep.
July. I don't know what the cultural issues are in the state, but we certainly want to know more about that.
Yeah, that I could I'll make a note of that, and then maybe we could talk further about that and really what we would need to think about if we wanted to move this to a legislative priority is to talk about what is the need, right? So what do we need from the legislators or policy to help further that? I really don't have formed thoughts on that myself. I just know that we've been struggling of late on our end. Other thoughts for priorities?
This is just one, I'll throw this out here. But I have been doing a lot of work in the mental health space, and I do think that and I don't know, I'm just saying this as a thought, but not necessarily because I have a specific policy, but or suggestion or idea, but looking at increasing training and building capacity for providers who are who are doing traditional mental health treatment, and then expanding that to having some expertise in autism. um I don't know how many of you were involved or saw the news on the state's application for the rural health grant, but one of the proposals that we put in, um, that I worked on with DCF, it was DCF proposal, but was to expand access mental health to have um, to hire some professionals who have expertise in autism. So then any providers could then call in and access that expertise. So that proposal is in the rural health application. But if for some reason Connecticut does not get approved for that application, that was like one of 31, I think, final projects that made it into our application. But if that doesn't, I think that that's a great way to
Mm.
easily build capacity across the state. And just for those of you who are members of ASDAC, we did sign a letter of support for the rural health uh, application specific to that proposal and project. But if it does not get approved for some reason, I would love to see us advocate for um, some ways to expand and build capacity for providers or have so that they have access to autism expertise instead of just trying to create new programs. Or, I think that a lot of families experiences, or you find one doctor that's really good, or, a PCP, or a therapist that's really good supporting people with autism, and then everybody flocks to that one person, the word gets out, right? But what we would love to see is that, what my personal opinion, what I would love to see is that there was a more capacity among providers across the state, or they had access to expertise. So just throwing that out there.
I think that's a great, oh, I'm sorry, Sarah.
No, go ahead, Carrie, and then Sarah.
Yeah, no, you started. I raised my hand right.
Sorry. I have to apologize too, because I have to pop off soon. But I think it's a great point, Tara, and I would really love to see providers flocking to that opportunity. I will tell you, recently we had an opportunity here with two highly renowned individuals in the field of not me, but two other people here, highly renowned, not and to provide an opportunity for current providers to enhance their skills and strategies in working with individuals. And we got a very low return rate. And I suspect that is because people are already, I mean, everyone's practice is full, right? And so folks who aren't necessarily even working with this population, but those who are, to your point, those who are beyond full with waiting lists, right? So I think it's a yes and potential solution, which it would be lovely to expand the repertoire of folks already working in mental health, in the mental health field. But I think also to have increased opportunities for folks who are maybe out there doing some community-based mentoring and job coaching, and less formal mental health, but really serving as such, not for folks who have significant mental health needs, but really who need to be connected and not and sort of preventing those cases of isolation and so forth. So that I say yes, and
Okay.
however we can get behind that. And I'm sorry.
Yeah.
Now, but
yeah. Thank you. I appreciate
Thank
it.
you, Carrie. Sarah?
So I entirely support that, Tara. I think that's really, really important. Just piggybacking on that, there might be some opportunity to think about adult primary care support individuals with autism spectrum disorders. We have, I'm a developmental behavioral pediatrician, and I have a transition clinic. And honestly, this should be something I know have a ton of resources for, and it is something that does not exist. I think there's one provider in the state of Connecticut that I know who actively sees individuals with IDD as a primary care provider. So there, really, that's another area in healthcare, because that would be helpful, because these individuals don't have any specialized support once they leave pediatrics.
And based off of, to piggyback off of what Carrie just mentioned about, even when some trainings and resources have been provided, they're not necessary. I mean, people are already so busy that may not make it on their priority list. Is there a way to, do you think that, because that was one of the ideas for the Access Mental Health, was that they had a team so that they could then call in and access, information. So, and in your, I'm just trying to get your perspective. Do you think that that's a better way to go, so that we could slowly maybe build skills, or give providers a resource so that they feel more comfortable supporting somebody who's coming into their practice?
Yeah, I mean, I think Access Mental Health is great. We use it in pediatrics, all the time. It's so useful in general. It's obviously at this point doesn't have an autism spectrum disorder
Right.
component, and that's what you're talking about, which I think is an excellent idea. Yeah, I think I mean, in the transition work, that I do, and I do, work nationally with, people in other states. I mean, this is a challenge for all of us, but
Mhm.
ways to support our colleagues in adult medicine, be it in mental health, be it in primary care, in whatever, capacity, we are trying to, kind of push our way into that and support them. But I think, yeah, without support, they aren't going to be that encouraged to develop
Mhm.
this niche but it's a niche that's so necessary. And I mean, people, like you said, would flock to them.
Mhm.
So I think it would be, finding ways to support our adult care providing colleagues.
And that was part of the access, the application too, was to expand to the adult population as well. So,
Yeah, great. Thank you.
Jennifer?
Just to add to the conversation, because I agree with everything that's already been said, Tara, you and I have also talked about the parity in mental health and then autism and all of the other levels of care that are available to individuals who just have a straight mental health diagnosis. I don't know how we can, if that's legislation or just, again, more training, more workforce development. I don't know what the answer to that is, but everybody else who might need a step down from a inpatient level of care, they have multiple steps that they can go through before going back home. Meanwhile, we have a population who, I mean, there's already a workforce shortage for the group of people who are supposed to keep these individuals stable at home, but there's also nothing in between. So they're going from the highest level of care back to home with sometimes still really intense behaviors.
Mhm. Mhm. I agree. And so that may be one of the additions too, is just
Yeah.
within autism and mental health, looking for, maybe not requesting funding for building a new program per se, but how can we
Or a
build
special rate for the programs that already exist that are willing
the
to
program?
also,
Yeah, right. Is there a way that we can build
Mhm.
that expertise within the system? Because people are doing it, there's people out there that are doing it. It's just a matter of, um, it's unfortunately, autism as a primary diagnosis is an easy way to discriminate. And I will say that because a lot of times I feel personally it's a discrimination. Um, y- to access those mental health services. So, but there is no, again, with parity, there is no other specific treatment, especially if there's no access to behavior services or anything else. There is no other specific treatment that that people with autism are going to be looking at. I mean, PT and OT are not going to fix a mental health um, issue that somebody may be having. So,
Yeah, but it'd be great, this is Toby again, it'd be great to know, and maybe you already know who they are, Tara, or other people on the call. Who are those physicians that are really good, or psychologists or whatever, who are really good that could do CLEs or provide training to build capacity for other primary care and specialists to like really, be able to deliver the supports that youth and young adults need,
mhm,
or adults need, so whether it's rural or urban, whatever, that there's capacity in the system to
mhm,
get the support they need.
yeah. And I'll
Tara,
answer sorry, Kim, I'll just answer Toby your question really quickly about the USETs because I did used to work there. Our USET is primarily focused on early childhood. They do a lot of work in that space, and not as much, and not saying that they wouldn't, but just saying that that is their primary area of expertise. So,
Yeah, it just seems like a great ripe area, like
well, and also
disregarding all the funding constraints or
I was
whatever.
yeah,
just
right.
gonna
I was
say
gonna
I
say,
their
know,
yeah.
I
their
know.
funding
If in
has
a
been cut.
normal
Yeah,
world, it might be, but I get
yeah.
it.
Yeah. Tara, one thing that might be also helpful under this area to talk about is pre-service. You know, at my organization, the nurses have actually gotten together and have done some work with CCMC and being able to work directly with students, interns,
Mm-hmm.
to be able to get them better prepared. And I think that's like a novel idea for me. And I don't know if it's been out there, but I really think that could be beneficial to think about how could we reach people before they even,
Mm-hmm. Like,
um,
is there a training program that could be developed? Like, could we work with, a partner like, you know, Carrie at Southern, I'll volunteer,
right.
that they could develop, a training program that then could be utilized, for young professionals or
Yeah.
people who are still in school. Okay. Yep.
Yeah. That's what I'm
Got it.
thinking.
I'll write it down.
Yeah. Adrian?
Hi, I'm not a member. I'm just wanted to introduce myself since we're almost out of time. I'm the chair of the Connecticut Profound Autism Alliance, and we were instrumental in getting House Bill 7108, which includes the needs assessment for autism, and also the need for more transparency for abuse and neglect, which is a whole other great big issue that we don't have time to talk about. But we talked about collaborating, and I love the idea of us collaborating because I'm pretty sure everyone in our world would support the things you're fighting for, BCBA to 26 and further, as well as a really thorough needs assessment. I don't know if you all know. So one thing is we wanted to invite you to our meeting. Not that everybody isn't busy enough, but we have meetings Tuesday at 7:30 and the next two meetings. We talked specifically about sharing with you all, if possible, would be on November 18th. That's a Tuesday at 7:30, or December 9th, a Tuesday at 7:30.
Are these in person or are they virtual?
No, we're Zooming.
Okay. Zooming is
Yeah.
good. Zooming
Yeah,
increases the
I-
odds.
we have had a few sort of party meetings where we all finally got together and spent time together. It was wonderful, but that's hard.
Yeah. Would you be willing to share the link with Tara, and then we can distribute it?
Yes, that's a great idea. Otherwise, it would be a mystery.
Thank you.
The other thing is, I don't know if everyone knows this, but my daughter, I have a daughter with profound autism, and she receives services from DDS. DDS does not track how many people they serve who have autism. So we've been pushing because we have a lot of people who do not get services. They're rejected by day programs, they're rejected by residential because their needs are too severe. And this is a significant number of people who are home with families, aging families. And man, it is tough. So now I know that every case manager for every person that gets is on the DDS rolls has a diagnostic code. ID, autism, maybe seizures, maybe Prader-Willi, maybe Down syndrome. So that data is there, but it hasn't been collected. So one of the reasons we were fighting for the assessment was which is a little different from the survey thing, which is a great idea too, is to get real clear data on how many people in DDS have autism. And each case manager could come up with that number, but DDS hasn't asked their case managers to do that. I guess I'm making my point that this data collection is so important to us because then we can go to the legislature and say, see, we need more BCBAs. We need more resources for people with these higher levels of need because there's best practices and DDS isn't really there. I mean, I love them in many ways, but this is a big problem. So it'd be great to work together. And I love hearing your interest in all this stuff. It's great to get to know you all. So
Thank
thanks.
you. Thank you. And yeah, share if you can share that link with Tara, she can get it out to us. And we appreciate the invite. It is
Okay.
helpful to collaborate with others.
Yeah.
On that note, it is 3:00 and I want to respect people's time. So thank you everyone for great conversations. Really appreciate it.
Thank you.